for the presentation.
Good morning, everyone. So I'm Dr. Gayatri. Today, I'm going to discuss about sickle cell disease in pregnancy and its anesthetic implications. Sickle cell disorder is one of the most common monogenic disorders of inherited hemoglobinopathies. It is most commonly seen in sub-Saharan Africa, South Asia, and Mediterranean countries. In India, most commonly seen in the tribal people of Maharashtra and Madhya Pradesh. Sickle cell disorder is a multi-system and multi-organ disorder. Pregnancy with sickle cell disorder has a reciprocal influence on each other, and their association is detrimental with subsequent increase in maternal and fetal complications. Coming to the molecular basis of sickle cell disease, it is an autosomal recessive disease arising due to the single gene mutation at the sixth position in chromosome number 11. Substitution of non-polar amino acid valine in place of polar amino acid glutamate in the sixth position of the beta chain of the hemoglobin molecule. As a result, normal adult hemoglobin A is replaced by hemoglobin S. These are the common genotypes of the sickle cell hemoglobinopathies and their characteristic features. Sickle cell disease occurs when hemoglobin S is inherited in the homozygous state, that is HBSS, or as a compound heterozygote along with another abnormal beta globin allele such as hemoglobin C, which leads to hemoglobin SC, or hemoglobin D, hemoglobin E, or hemoglobin O or F. And it can also be accompanied by beta thalassemia. Beta thalassemias, in association with beta thalassemias, there can be absent beta globin chains or reduced synthesis of the beta globin chains. Hemoglobin SS, that is sickle cell anemia in the homozygous state, and hemoglobin beta 0. These are the most severe forms of sickle cell hemoglobinopathies. Coming to the pathophysiology of the sickle cell disease, it can be mainly categorized as hemoglobin S polymerization, vaso-occlusion, endothelial dysfunction, and also because of a new theory called sterile inflammation. The main precipitating factors include dehydration, acidosis, hypoxemia, hypothermia, and hypotension. Hemoglobin S polymerization. In sickle cell disease, initially RBC undergo rapid but reversible change in the shape of RBC on deoxygenation. When oxygen tension decreases, hemoglobin in the deoxygenated state polymerizes into insoluble aggregates, leading to sickle cells, which further causes increased blood viscosity, which further causes decreased circulation and increased exposure to low oxygen tension, which can lead to more sickling. It follows as a vicious cycle. Repeated sickling cycles and extensive polymerization of hemoglobin S produce erythrocytic metabolic abnormalities and damages its membrane, which leads to irreversible sickling regardless of the oxygen concentration. And it can lead to intravascular hemolysis of the RBC. RBC lifespan gets reduced to 12 days instead of 120 days of normal RBC. This is a vicious cycle which shows because of genetic abnormality, hemoglobin S leads to sickling or deoxygenation in presence of the precipitating factors, and it leads to venous stasis, which leads to hypoxia, and it again causes increased sickling. And as the sickling process continues, the organs get infected, ischemia, and pain crisis ensues. Next theory is vaso-occlusion theory. It is a complex process involving RBCs and endothelial cells as well as WBC and platelets. Direct contact with sickle red cells, free heme and hemoglobin, and hypoxia-induced reactive oxygen species is believed to activate the endothelial cells. Increased erythrocyte adherence results in the formation of heterocellular aggregates, which includes RBCs, WBCs, platelets, that block small blood vessels and ultimately cause local hypoxia. The factors which are involved are the selectins, vascular cell adhesion molecules 1, major leukocyte chemoattractants on endothelial cells cause adhesion of RBCs and WBCs. This is the picture which shows the vaso-occlusion process. And if the autonomic nervous system is involved in case of mental stress, fear, anxiety, pain, cold, this will cause more vasoconstriction and more vaso-occlusion of the vessels. Coming to the endothelial dysfunction, cell-free hemoglobin in plasma causes nitric oxide scavenging, resulting in impaired endothelial function and enhances proliferative vasculopathy in the respiratory vasculature as well as systemic vasculature. The new theories regarding sterile inflammation, heme and its oxygenated form hemine act as pro-inflammatory and procoagulant milieu of sickle cell disease. It is marked by activation of WBCs, platelets, endothelial cells, tissue factors, cytokine storm, nitric oxide depletion, and reactive oxygen species generation. Coming to the clinical features of the sickle cell disease is a severe form of sickle cell disorder. It affects all the body systems, whereas sickle cell trait is usually asymptomatic. As we know, in sickle cell disease, there will be 90% of HbS and 8% of hemoglobin F, 2% of HbA2, and no HbA. While coming to the sickle cell trait, there will be less amount of HbS when compared to sickle cell disease. Repeated cycles of hemolysis, inflammation, and ischemia cause acute and chronic clinical features of the sickle cell disease. It is accompanied by intermittent periods of severe pain and complications with relative normalcy in between such episodes. Coming to the acute events and their manifestations. Painful crisis, also known as vaso-occlusive crisis. It presents as pain, mainly if it affects the hands, it is known as dactylitis, and it can also be present in long bones like femur, sternum, ribs, or back. And more acute event is infection. It can manifest as bacteremia, osteomyelitis, pneumonia, or urinary tract infection. Acute presentation of anemia. It can manifest as splenic sequestration, transient aplastic crisis, and transfusion reactions. Organ damage can manifest as stroke, mainly neurological stroke, acute chest syndrome, splenic infection, and papillary necrosis. Coming to the chronic events of sickle cell disease, the renal involvement can manifest as renal infection, hematuria, renal failure, or hyposthenuria. Cardiorespiratory involvement manifests as restrictive cardiomyopathy, congestive heart failure, pulmonary hypertension, restrictive lung disease, and pulmonary embolism. Neurological involvement involves ischemic and hemorrhagic stroke. Orthopedics, avascular necrosis of the femoral head, or osteomyelitis. Coming to the hepatic, it can manifest as jaundice or cholelithiasis because of increased amount of conjugated and unconjugated bilirubins. Ophthalmic involvement manifests as retinopathy. Dermatology as leg ulcers, spleen manifests as infection or hypersplenism. Coming to the transfusion related or treatment related. Acquired red cell antibodies, hyperhemolysis are because of transfusion related. Because of uses of hydroxyurea, it can lead to neutropenia. Coming to the diagnosis of sickle cell disease, mainly there will be low amount of hemoglobin, elevated reticulocyte count, presence of sickle cells in the peripheral blood sphere, and we can diagnose with rapid sickle cell solubility test using sodium metabisulfate. Electrophoresis is a gold standard test for diagnosis using standard alkaline gel isoelectric focusing high performance liquid chromatography. Normally, we should advise prenatal screening for couples having a family history of sickle cell disease. We can diagnose in vitro by amniocentesis or chorionic villus sampling, where we can use fetal cells to diagnose with restriction endonucleases. Newer methods are based on DNA-based or antibody-based tests. In pregnancy, there will be more occurrence of vaso-occlusive crisis or acute chest syndrome, anemia. And first, coming to the vaso-occlusive crisis in pregnancy, it is also called as painful crisis. It is an acute episode of pain in sickle cell disease, not attributable to any other pathology. The presenting complaint of vaso-occlusive crisis or painful crisis is pain. It primarily involves bone pain, which usually involves lumbar spine or knee joint or femur. Abdominal pain can also be present. This is mainly due to the gastrointestinal tract involvement, mainly liver or spleen, or it can be due to the radiation from the ribs also. Abdominal pain, the incidence of vaso-occlusive crisis is the progression of pregnancy and peaks during the third trimester. Sometimes the abdominal pain of VOC may mimic an acute abdomen. It will be complicated to diagnose between these two because there will be gravid uterus. About 50% of the participants with sickle cell disease can have at least one episode of vaso-occlusive crisis during the pregnancy. Coming to the management of vaso-occlusive crisis, the patient should be immediately admitted to the hospital, should provide analgesics, bed rest, adequate hydration, and supplement oxygen therapy in case of desaturation, that is SpO2 less than 94%. Analgesics should be provided within 30 minutes and they will take action within 1 hour. A multimodal approach with epidural analgesia along with other modalities for pain management is advised. Anxiolytics and sedatives may be supplemented. Transfusion therapy is advised if there is severe anemia with symptoms or vaso-occlusive crisis is complicated. Coming to the next complication in pregnancy, that is acute chest syndrome. The appearance of new pulmonary infiltrates involving at least one lung segment on chest X-ray, along with chest pain, fever more than 38.5 degrees centigrade, tachypnea, wheezing, or cough. It can be defined as acute chest syndrome in pregnancy. Main precipitating factors will be infections and fat embolism after bone marrow infection or pulmonary infection. Management includes supplemental oxygen therapy, bronchodilators, adequate analgesia, appropriate antibiotics in case of infections, adequate hydration, and blood transfusion if needed. Coming to the medical management of sickle cell disease, hydroxyurea. It is a potent ribonucleotide reductase inhibitor, inhibits intracellular polymerization and enhances the production of hemoglobin F in sickle cell disease. It is potentially teratogenic drug, so it is advised to discontinue the drug at least 3 months before conception. Angiotensin converting enzymes and angiotensin receptor blockers routinely used in patients with sickle cell disease with significant proteinuria as they reduce proteinuria and microalbuminuria. These are not safe in pregnancy and should not be used in women who are trying to conceive. There are some new therapeutic drugs which target specific pathophysiological pathways, such as interrupting vaso-occlusion by reducing cellular adhesion, inflammation, hypercoagulability, and prevention of intracellular HbS polymerization through HbF induction or hemoglobin stabilization. For example, crisanilizumab, rivipansine, poloxamine 188, heparins, and sevuparin. Coming to the nutritional supplements, omega-3 fatty acids purified from fish oil can be supplemented. It acts as an antioxidant, antithrombotic, and anti-inflammatory drug. Coming to folic acid, normally in pregnancy, we advise 1 milligram of folate for patients regularly. But in sickle cell disease pregnancy, we have to advise 5 milligrams pre-conceptionally and also continued throughout the pregnancy. Role of blood transfusion. Anemia is one of the complications which can aggravate during pregnancy, but normally these patients are frequently anemic. So only blood transfusion is advised in these patients when they have hemoglobin level more than 2 grams per deciliter from the baseline, or if there is any hemodynamic compromise, or there is any risk of any critical organ complications. Acute anemia can occur in these patients as a result of increased hemolysis, hepatic or splenic sequestration, or red cell aplasia from parvovirus infection, or pregnancy-related causes including abruption. Prophylactic transfusion, either simple or exchange transfusion, will be considered in these patients in case of multiple pregnancies, or women previously on hydroxyurea therapy for severe disease, or significant complications during previous pregnancy. Exchange transfusions should be initiated, that is, if there is less than HbS levels to less than 30%, and it should be initiated by the hematology team. The main role of blood transfusion includes decrease in percentage of HbS, increase in oxygen carrying capacity, improved hemoglobin, suppression of sickle erythropoiesis on dilution of HbS, thus preventing the sickle cell crisis. Simple or top-up transfusion should be made by Buffy could pour HbS pre-washed RBC so that it increases the overall number of normal RBC and for immediate benefit in severe anemia, acute aplastic crisis, and before or during surgery. Exchange transfusions benefit stroke and acute chest syndrome. Aims to remove HbS to less than 30% by replacing it with HbA with maintenance of baseline hematocrit. When planned, preoperative blood transfusion should be given 14 days before surgery, and if not possible, at least 24 hours before surgery. The transfusion benefits must be balanced against the various risks, that is, infections, iron overload, alloimmunizations, transfusion reactions, hyperhemolysis, and an individualized plan made based on baseline hematocrit, end organ pathology, anticipated blood loss, and planned mode of delivery. Mainly, the risks of transfusion includes alloimmunization, delayed hemolytic transfusion reactions, and hyperhemolysis. Alloimmunization is the development of non-ABO antibodies. It can develop in 12 to 29% of the patients with SCD. It is associated with delayed hemolytic transfusion reactions, and also it can delay the sourcing of compatible blood. As a minimum, red cell should be ABO, RH, and KEL compatible. If we are planning red cell transfusion, for simple transfusion, the red cell should be 10 days old, and if possible, for exchange transfusion, it should be less than 7 days old, and also HbS and cytomegalovirus negative. Delayed hemolytic transfusion reactions typically occur 7 to 10 days after the transfusion, mainly present with pain, jaundice, fever, rapid decrease in hemoglobin, raised reticulocyte count, positive antiglobulin test, and formation of new allo antibody. Can be mainly treated with intravenous immunoglobulin and methylprednisolone. Hyperhemolysis is also characterized by severe sickle pain, rapid decrease in hemoglobin concentration after transfusion to below that of before transfusion. Relative reticulocytopenia, negative or weakly positive DAT, and hemoglobinuria. Coming to the transplantation and gene therapy, stem cell transplant with matched sibling donors is the only curative modality for patients with sickle cell disease. In children, it is only possible in patients with severe disease without end organ dysfunction through the use of myeloablative conditioning regimens, which are toxic. However, using reduced toxicity conditioned regimens allows successful transplantation in adults and effective in preventing future painful VOC and stroke. Coming to the gene therapy, it is under clinical trials for genes encoding anti-cyclin beta globulins and gene correction therapy for hemoglobin F induction. Impact of SCD on pregnancy and delivery. The physiological changes of pregnancy and delivery may exacerbate sickle cell disease. Conversely, the presence of sickle cell disease can complicate the course of pregnancy. So before planning for pregnancy, we should optimize the woman's underlying condition. Good hydration, avoidance of alcohol, folate supplementation, that is 5 milligrams daily to avoid anemia, blood transfusion if severely anemic with thorough hematological and cardiovascular workup should be followed. All sickle cell disease patients have already pre-existing anemia, increased oxygen demand, and circulatory overload, which are exacerbated by normal physiology of pregnancy. The aortocaval compression and venous stasis of pregnancy worsen the baseline clinical condition of SCD patients. Hypercoagulable state in pregnancy favors sickling and also increases the risk of thromboembolic phenomenon like deep vein thrombosis or cerebral venous thrombosis. Preeclampsia in the sickle cell disease is difficult to diagnose because it will present with symptoms like abdominal pain, hypertension, kidney dysfunction, congestive heart failure, which can be the manifestations of sickle cell disease. Increased incidence of preterm deliveries, life-threatening placenta previa and placental abruption, postnatal sickling complications including ACS, VOC, and stroke. Impact on fetus, exaggerated risk of spontaneous abortions and stillbirths. There is also increased risk for prematurity, low birth weight, short per gestational age, intrauterine growth retardation, and perinatal mortality. Perioperative management of patient with SCD. Obstetric management includes a multidisciplinary team comprising of obstetricians, hematologist, anesthetist, and a nurse trained in high-risk antenatal care. These are some of the pearls in antenatal care of patients with sickle cell disease. First most is review by hematologist with screening for end organ damage should be done. We need to avoid precipitating factors of sickle cell crisis like hypothermia, dehydration, hypoxia, like this. And early medical treatment for persistent vomiting should be advised as it can lead to dehydration and sickle cell crisis. We have to advise for influenza vaccine if not administered in the previous year. Normally, sickle cell disease patients will have an immunization status, vaccination status. We have to go through that vaccination schedule. These people are advised to take Haemophilus influenza type B on conjugated meningococcal type C vaccine, at least single dose if not received as a part of primary vaccination. Pneumococcal vaccine should be given every 5 years. Influenza and swine flu vaccine are given annually. We have to check the hepatitis B vaccination schedule also for these patients. And coming to the daily folic acid supplementation and prophylactic antibiotics, if indicated, drugs that are unsafe during pregnancy should be stopped. With sixth pearl, iron supplementation if there is laboratory evidence of iron deficiency. And if history of multiple transfusions is present, then review for iron overload and allow antibodies. Advised to give low dose aspirin, that is 75 milligrams OD from 12 weeks of gestation to reduce the risk of preeclampsia. We have to advise prophylactic low molecular weight heparin during antenatal hospital admissions. Transfusion, if indicated in severe anemia, and exchange transfusion in case of stroke and ACS until after delivery. Coming to the allocation, Coming to the pre-anesthetic assessment, a careful assessment of all organ systems is necessary. Goal of assessment is to determine the risk of peripartum sickle cell disease complications and organ dysfunction. History of cardiac or pulmonary disease, advanced age and infection. A detailed hematological evaluation, which includes CBC or hemoglobin electrophoresis, should be performed. And we have to perform chest imaging or pulmonary function test, ECG and echo. Banu phone కనిపిస్తుంది. Sorry for the disturbance. And is coming to the anesthetic management, pre-anesthetic assessment includes a careful assessment of all organ systems is necessary. The goal of assessment includes determine the risk of peripartum sickle cell disease complications and organ dysfunction. Careful history and examination includes transfusion history, number of hospital admissions, and timing of
The slides are not seen.
Madam,
Sharing is not happening, or it is disconnected.
ma'am, are you able to hear my voice?
I can hear you, but the thing is, slides are not seen. Just check with anybody else.
1 minute, ma'am. Now, ma'am?
No.
No.
Anybody else? Please respond.
Yes, ma'am, 1 minute.
Yeah, now it is seen.
Okay, ma'am.
Make it a slideshow.
Okay, ma'am. Sorry. Can I start from here, ma'am?
Yeah, good.
Okay. So coming to the anesthetic management, we have to evaluate the patient carefully for all organ systems. The goal of assessment determines the risk of peripartum sickle cell disease complications and organ dysfunction. We have to go through the careful history and examination. We have to take history of transfusion history, number of hospital admissions, timing of crisis in pregnant patients. We have to take history of cardiac or pulmonary disease, advanced age, or any risk of infections. A detailed hematological evaluation is necessary to, we have to rule out complete blood count, hemoglobin electrophoresis is advised. Chest imaging and pulmonary function tests to evaluate the patient with any lung abnormalities. ECG and 2D echo is advised to test the functions of heart or any pulmonary hypertension is there or not. Oxygen saturation and ABG analysis should be performed. Baseline oxygen saturation should be noted in the pre-anesthetic clinic. Renal function tests are advised as these patients will have chronic renal dysfunction because of SCD. Blood screening for various alloantibodies and extensive cross-matching must be done before the blood transfusion. These are the preoperative investigations in SCD with pregnancy and their significance. Hemoglobin to rule out anemia, plasma urea or creatinine because of baseline value lower than non-SCD participant at early stage but raised levels as disease progresses. Urine dipstick to rule out hematuria and proteinuria, pulse oximeter for low oxygen saturation. If it is below 94%, it oxygen is advised. LFT for abnormal viral serology, chest X-ray for abnormal lung infiltrates which are present in 10 to 15% of patients. Blood cross-matching should be done for prior antibodies and extended cross-match for rare groups. Pulmonary function tests for severe pulmonary pathology, ABC analysis for iron overload due to multiple transfusions, ECG right ventricular strain pattern due to lung disease, echo for cardiopulmonary involvement, neurological imaging for motor, cognitive, and psychological deficits. Labor analgesia in SCD with pregnancy. For an anesthetic assessment as a routine in the third trimester and if high risk should be referred at an early stage. An effective labor analgesia plan is an integral part of the management of the laboring parturient with SCD because of increased risk of sickle cell crisis. Central neuraxial analgesia is a gold standard which involves epidural analgesia and combined spinal epidural analgesia. It is ideal in patients with opioid tolerance or sickle-related pain in the lower body. Newer method is Antonax. It is an effective option but not to be given for long durations due to the neurobehavioral hazards of the nitrous oxide on neonates. Anesthesia for cesarean section. Which includes preoperative preparations. We have to thoroughly assess the patient preoperatively. Parturient should be admitted at least 1 day before the surgery. Chest physiotherapy is advised preoperatively as well as continued postoperatively in addition to the prophylactic antibiotics as these patients are more prone to chest infections. Good hydration status must be maintained. We have to give minimal preoperative fasting period. That is, we should allow at least oral hydration at least for 1 to 2 hours before surgery. If the oral hydration is not possible or inadequate, then we can allow intravenous fluids. We need to avoid hypothermia, hypoxemia, hypovolemia, acidosis, and hypotension. Coming to the advantages and disadvantages of regional anesthesia and general anesthesia. Regional anesthesia advantages include optimal pain control, low risk of DVT, less incidence of sickle cell crisis, less intraoperative blood loss, decreased risk of pulmonary aspiration. The disadvantages include hypotension, bradycardia, risk of PDPH, and as the patient is awake, it can lead to more anxiety. Coming to the general anesthesia, the advantages include less hypotension, better control of ventilation and oxygenation, and less anxiety. The disadvantages include inadequate analgesia, large blood loss, risk of failed intubation, risk of pulmonary aspiration, and postoperative sedation and hypoventilation. Regional anesthesia is largely safe for cesarean section in SCD with precautions like adequate hydration, avoidance of hypotension, and careful monitoring of the level of the block to prevent respiratory depression. General anesthesia, special attention should be paid to effective oxygenation during intubation. Pre-oxygenation, avoidance of hypotension, avoidance of long-acting opioids, and muscle relaxation should be done. In obese parturient, ramping position is advised. Intraoperatively, normocarbia, normothermia, and normal hemodynamics should be maintained. Maintenance of temperature should be done by using pre-warmed blanket and maintaining the warm IV fluids. Judicious use of fluids depending on the preoperative cardiac status and timely replacement of blood loss with blood products. ASA standard monitoring, neuromuscular monitoring should be practiced, ensuring full reversal before the tracheal extubation. In an otherwise healthy parturient with well-preserved cardiopulmonary status and mild anemia, regional anesthesia should be preferred with precautions. In severely anemic, decompensated parturient and in those who are planning for postoperative ICU stay, then general anesthesia is advised. The choice of anesthesia is not as important as the care with which it is administered. Coming to the postoperative management, pain management is the main one. A multimodal approach consisting of combination of local or regional blocks, oral or IV drugs, patient-controlled intravenous or epidural analgesia, and nurse-controlled analgesia are required. Opioids, mainstay for the treatment of vaso-occlusive crisis and postoperative pain in patients with sickle cell disease. Side effects include nausea, vomiting, which can confound the diagnosis of an acute abdomen in vaso-occlusive crisis. Sedation and delayed respiratory depression, which can itself precipitate VOC. Limitations include opioid tolerance, dependence, and addiction. Coming to the NSAIDs and acetaminophen, they can be used in mild to moderate pain. NSAIDs can be used along with mild opioids to relieve chronic pain management. Side effects of NSAIDs include oligohydramnios, early closure of ductal arteriosus, gastritis, kidney dysfunction, and antiplatelet activity. Ketamine in severe pain unresponsive to standard therapy and in patients with opioid tolerance or opioid-induced hyperalgesia, ketamine is used. It is a psychomimetic drug and can influence the fetal outcome. Epidural analgesia in treating painful VOC, perioperative pain, and labor pain. Regional blocks like bilateral tap block and ilioinguinal iliohypogastric nerve blocks are advisable in the postoperative period. Postpartum care. The first 48 hours requires close monitoring as there is increased risk of VOC. The degree of anemia must be assessed following the intrapartum blood loss in both NVDs and LSCs. Blood should be replaced adequately and timely. Risk of thromboembolism can be reduced by thromboprophylaxis, hydration, and early mobilization. Thromboprophylaxis with low molecular weight heparin for 7 days after NVD and a period of 6 weeks following LSCs. Antithrombotic stockings during the purpurium period are advised. Postoperative respiratory complications and wound infections can be avoided by antibiotic prophylaxis along with chest physiotherapy. NSAID is routinely recommended in the postpartum period. Sickle cell trait in pregnancy. It has a benign clinical picture. Most patients live normal, healthy lives. RBCs do not sickle till partial pressure of oxygen drops less than 15 mm of mercury and show sickling only under extraordinary physiological conditions. Lifespan of RBC is normal. Usually no hematological manifestations are seen and if present, mild and mostly subclinical. Pregnant patients slightly more susceptible to asymptomatic bacteriuria, pyelonephritis, and hematuria. Rarely splenic infection at high altitude, venous thromboembolism, and chronic renal disease can be manifested. Sickle cell trait is linked with adverse outcomes in pregnancy like preeclampsia and prematurity. Same guidelines are used as we manage with sickle cell disease with pregnancy. Thank you.
So much is there. Huh?
So much is there, sir.
Very nice, very elaborate presentation. But can I add one thing, Gayatri?
Yes, ma'am.
Actually, you were mentioning about NSAIDs in the post-operative pain management and all. But only thing is that you have to constantly monitor for the renal functions, because if any history of any crisis before or during, so there may be some variation in the the kidney function test. So say monitor and accordingly you can.
Yes, ma'am. Yes.
That you have to mention all the time.
Okay, ma'am. Okay.
How many cases you come across, Doctor?
Sir, recently we had done one case, sir, around 1 month back, I think. Not 20 days back, I think, here.
So, ఏమైంది కేసు?
కేసు చాలా సేఫ్ గా అయిపోయింది సార్. యాక్చువల్ గా ఆ పేషెంట్ కి ప్రెగ్నెన్సీ వరకు తను సికిల్ సెల్ డిసీజ్ హోమోజైగస్ స్టేట్ అని తెలియదు సార్. ప్రెగ్నెన్సీలో ల్యాండ్ అయిన తర్వాతే తను షీ కేమ్ అక్రాస్ దట్ హోమోజైగస్ స్టేట్ అని మనం ఇక్కడ ఇన్వెస్టిగేషన్స్ చేసిన తర్వాత హిమోగ్లోబిన్ కౌంట్ రెగ్యులర్ గా లో వస్తుంటే మేడం పెరిఫరల్ స్మియర్ చేయిస్తే దాంట్లో సికిల్ సెల్ హిమోగ్లోబిన్ నెక్స్ట్ ఎలక్ట్రోఫోరసిస్ పంపిస్తే హోమోజైగస్ స్టేట్ అని తెలిసింది సార్.
ఓకే.
బట్ వితౌట్ ఎనీ కాంప్లికేషన్ సేఫ్ గా అయిపోయింది సార్ ఇక్కడ.
సో జస్ట్ టు హ్యావ్ ఎ జిస్ట్, as you said, till 2 hours prayer also you have to make you should not make the mouth dry అన్నారు కదా. సో రొటీన్ కేసెస్ కి వీటికి డిఫరెన్సెస్ ఒక్కసారి కంక్లూడ్ చేస్తారా
సార్?
ద రొటీన్ కేసెస్ కి అండ్ ఈ కేస్
డిఫరెన్సెస్ సార్.
అంటే ఫర్ ఎగ్జాంపుల్
ఫాస్టింగ్ పీరియడ్ మినిమం అంటే చాలా మినిమం ఉంచాలి సార్. వి నీడ్ టు మేక్ అట్లీస్ట్ అంటే 1 to 2 hours లో. అవును సార్. మినిమం 1 to 2 hours ఓరల్ హైడ్రేషన్ అలౌ చేస్తూ ఉండాలి సార్. ఇఫ్ ద పేషెంట్ ఈస్ నాట్ ఏబుల్ టు టేక్ ఓరల్ హైడ్రేషన్, దెన్ వీ హ్యావ్ టు గో ఫర్ IV హైడ్రేషన్. అండ్ ఎనీ ప్రెసిపిటేటింగ్ ఫ్యాక్టర్ లైక్ హైపోథర్మియా, హైపోక్సియా, హైపోటెన్షన్ ఏదైనా కానీ మనం ముందుగానే ప్రివెంట్ చేసుకోవాలి సార్. అంటే ల్యాండ్ అవ్వకుండా పేషెంట్ క్రైసిస్ లో సార్.
Do you think that going for invasive monitoring is better for these patients, or even non-invasive is okay?
నార్మల్ గా అయితే I don't think it is required, sir. We take all the precautions.
Yes, sir. Round Prasad garu.
Good morning, sir.
Cheppandi.
Gayatri, how hemoglobin adult differs from hemoglobin fetal? And what is the P50 of adult hemoglobin and pediatric? DNB students can answer this. Adult hemoglobin has high affinity for oxygen, so it would release low affinity for oxygen, so it releases oxygen easily. Fetal hemoglobin has high affinity for oxygen, so it carries more oxygen. This is what is double Bohr effect. On one side, maternal circulation, maternal hemoglobin gives, because of the alkaline pH, it gives off oxygen, and in fetal circulation, it tends to take more oxygen. And P50 also differs of adult hemoglobin and fetal hemoglobin.
Adult P50 is 27, sir. Fetal hemoglobin is 19.
Yes. So తక్కువ ఉంటే ఎక్కువ అఫినిటీ ఉంటుందా, ఎక్కువ ఉంటే తక్కువ అఫినిటీ ఉంటుంది?
తక్కువ ఉంటే ఎక్కువ అఫినిటీ ఉంటుంది. Fetal hemoglobin is having more affinity for oxygen.
Yes.
ODC curve is shifted to left when compared to adult.
Yes, sir. వీటికి ఇంట్రాయిట్రియన్ ఎక్స్చేంజ్ ట్రాన్స్ఫ్యూజన్స్ ఏమన్నా ఉపయోగిస్తాయా?
Hello, Gayatri madam, good morning madam. Hello.
Sorry, sir, network connection poor. Hello.
Madam, any experience of doing lab analysis for this sickle cell pregnancy cases, madam?
No,
Any
sir. No.
on this?
No, sir. No, sir.
Any seniors, madam? Doing lab analysis in sickle cell pregnancy cases?
No, sir. No, sir.
Okay. One more thing, madam, apart from your topic, while giving general anesthesia, especially for lab surgeries in sickle cell patients, any specific parameters or specific precautions to be taken, madam, especially when doing lab surgeries in sickle cell cases?
Lab surgeries, we have to maintain normocardia, sir. We should prevent hypoxia.
Sir, Raman Prasad, sir, any comments on this, sir? Lab
అదే
surgeries.
సార్, అదే అసిడోసిస్ ప్రివెంట్ చేయాలి సార్. అంటే మేడం చెప్పినట్టు హైపాక్సియా, నార్మోకాప్నియా మెయింటైన్ చేయాలి. తర్వాత if you want planning for a spinal or epidural, you see that platelet count is a minimum 60,000. ఇంకేమైనా ఉన్నాయా ఓంకార్? నీకు తెలిసి చెప్పు.
Even hypoxia, hypercarbia, and dehydration. Yes.
Including hypothermia in wrong cases. I think that also should be taken care.
లైఫ్ స్పాన్ ఆఫ్ ఆర్బీసీ ఇన్ సికిల్ సెల్ ఎనిమియా ఎంత అమ్మా?
12 days.
Sickle cell anemia, sir. 12 days, sir.
కాదు, సికిల్ సెల్ ఎనిమియా లైఫ్ స్పాన్ నార్మల్ is 120 days, no? RBC
Homozygous, it is 12 days.
12 days.
12 days.
12 days.
12 to 20 days they mention. It is
75% lifespan gets reduced. Will be around 12 to 20.
So HbA1c, what is the role in sickle cell anemia?
సార్ మీ లాస్ట్ క్లాస్ అటెండ్ అవ్వాలని చెప్తారు. HbA1c ఉపయోగం లేదని మీరు ఆల్రెడీ చెప్పేశారు.
అవును సార్.
లాస్ట్ క్లాస్ లో మీరు అడిగారు క్వశ్చన్, చెప్పలేదు, మీరే చెప్పారు రీజన్. బికాస్ ద RBC లైఫ్ స్పాన్ ఇస్ లెస్, సో దేర్ ఇస్ నో వాల్యూ ఆఫ్ HbA1c అని చెప్పారు. నేను విన్నాను, అక్కడే నేర్చుకున్నాను.
థ్యాంక్ యూ సార్.
ఇంకా ఏమైనా ఉంటే చెప్పండి సార్. Shama, Gayatri, any other tricks or trades to save the patients? Thank you, Ma. Thank you, sir. Srikanth. Thank you, Srikanth.
Thank you, sir.
Thank you, sir.